So we are finally going to do your HESI review, and it is recording. Welcome to Sunday brunch. Sunday brunch with Professor Bogart. So let's do our cahoots and see what goes on. You can play along with it. I think it makes it more fun for y'all. I don't look at answers and rights and wrongs, and I don't look at that. This is here for you to stimulate some cognitive awareness and trying to, again, showing you something, again, repetition, because I firmly believe it works. Yes, dear, come. Okay, for 1 second. Hold on. Come on, my dear. Coffee. No, I won't have time for that, but thank you. That's my coffee, my little Cuban coffee. All right, let's get her going. HESI Review 2022. Remember, I have 2 reviews out there, guys. One I did last week and this one. What is probably the single most important influence on growth at all stages of development? Does it matter if you're an infant, if you are even an adult? No, we need nutrition. Without nutrition, our body, especially infants, we won't develop the way we should. Cognitively, we'll have delays. So nutrition. You're going to hear that for your whole life. Frequent developmental assessments are important for which reason? So you've learned when children sit up, when they roll over, when they pincer grasp, build blocks, walk, all of these things. Why? So we know if something is stopped, that we're not progressing forward, or let's say we're 7 months old and our head is still lagging back as we pull them up, something's wrong. So we need to get it investigated, and we can institute early intervention. And that can bring these infants almost back to where they should be. The head to tail direction of growth is referred to, and it's called cephalocaudal, cephalic, think of head, okay? And that's just head to toe, the way we just lift the head up and then we end up walking. Makes sense. What is the single most important factor to consider when communicating with children? So the developmental level of that child. So how old is the child? What words do they understand? How do I first approach that child so that they're not fearful from me? Because if you cannot communicate to a child and you're going to be a pediatric nurse, you're not going to be able to get anything done. You're not going to be able to take a blood pressure because they don't understand you. So developmental level, get down on it, open up, the situation, talk about their shirt, the older kids, or their cute eyes or the curls, doesn't matter. Get down there, and then you could get whatever you need done, the child will do after they become your friend. What 2-year-old child pain assessment tool should the nurse use? 2-year-old, what is the pain tool? And you got it. Thank you. Remember, FACES does not start till preschoolers, ages 3 and 4. You will use the FLAC tool, which talks about their faces, their legs, their activities, crying, consolability, which is FLAC. It'll tell you what their pain level is. So very good. Good job, guys. You've been studying already. What is priority treatment for a child with dehydration due to profuse vomiting? We know dehydration is very scary with children. So they're vomiting. We're not going to put anything in their mouth. We're going to give the bolus of fluids they need. And remember, we don't bolus anything with glucose, sugar, and we never add potassium until after they urinate. Those are two big things that we need to remember in taking care of a vomiting child and the fluids that we use. The first expected fine motor developmental milestone for an infant begins with what? Fine motor, remember F, fingers, gross motor, I call it get up and go, 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 like Paw Patrol. So the first fine motor is what we call a reflex palmar grip. Put your finger into the palm and they close it on a reflex. Many parents think that, oh, isn't that sweet? My little baby just gave me a hug. I won't tell them any differently. An 8-month-old infant should be expected to perform which fine motor skills? So an 8-month-old definitely is going to have a voluntary grasp for sure. And now we're into sitting them down in the high chair and putting the Cheerios or those little puff things, and they're going to smash them with a couple fingers and get them in their mouth. And eventually by about 11 months old, it'll be more fine with 2 fingers that are going on. But we call that the crude, those Cheerios in the face. In general, an infant should triple their birth weight at how many months of age? And if we know that they haven't tripled their weight or they're over tripled their weight, they're either undernourished or overnourished. So very important growth and development concept. Yes, 12 months, triple. 6 months, double. RN assessing a 2.5-year-old toddler should report which finding to the provider? So if you're reporting something, it means it's not right. So we know that by the age of around 2, the head and the chest should be the same or the head should be more. If we see that it is not and the head is still bigger than the chest, something's going on. It needs to be reported and they need to investigate it. It could be hydrocephalus, it could be a brain tumor, could be something. They might need to do some sort of surgery to close it or shape it. Something's going on. A 2-month-old infant with cradle cap, what should the nurse tell the parents and how to treat it? So cradle cap, we've got this crusty white stuff, it's flaky. Wash it, soap and water, absolutely. You can even put mineral oil there, but softly brush it with a brush or softly comb it with a comb, but very softly. Because remember, we have those fontanelles up there, but we can treat it like that. According to Kohlberg's pre-conventional level of moral development, a preschooler who has moral reasoning, what do they understand? What do they show? What is Kohlberg all about? Remember I told you, you really need to go back and review Erickson and review your Piaget. These are questions that you will see on HESI and your NCLEX. So you wouldn't be surprised. So Kohlberg's all about good and bad, and good has consequences and bad has consequences. And children, becoming toddlers are understanding that good and bad. Which nursing action is appropriate to teach a preschool age child about a scheduled procedure? They need to go in and let's say they need their tubes put in their ear. And there's certain things that must be done. They're going to be placed in different places. So let them have a doll, and this is what we're going to do, and this is how it feels, and this is the procedure, and mommy and daddy will stay with you. And many times today, we even have the parents walk the child into the operating room with one parent until we can give them gas and put them out. And I think that is the best way to alleviate stress with the child, plus having them aware of what that mask is, what the room looks like, etc. Before
I'm
performing
sorry.
a physical assessment on a toddler, the nurse should do what to cooperate? Cooperation. I'll answer you right after this question, sorry. So we know children are afraid of the equipment and everything hurts. So again, let them, play with the equipment, let them touch it. Yes, what was the question you wanted to ask?
I don't see the Kahoot anymore, so I was just wondering if I was supposed to be, or am I supposed to be on Kahoot?
Okay, you should be on your phone that you can answer it, and you could be on your computer on my Zoom and you can watch it go by.
Thank you.
No, you're welcome. Not a problem. In terms of language and cognitive development, a 4-year-old child would be expected to do what? So preschooler, preschoolers is that change, that toddler where they're me, mine, no, no. And then the 4-year-old child, now the preschooler, they really become more aware of your feelings and actually their own. At this time, they're pleasers and they want to do things. So simple commands, putting your sink in dishes in the sink, put your shoes by the door, put your laundry in the basket. These are things that they should be able to do. Simple commands. In fact, they want to do them. Parents are concerned their 8-month-old child is not developing like the older child. What is normal for 8 months? According to the growth and development charts. And remember, forget you have children when you do a PEDS exam. Only know what you've been taught. And at this point, they should be able to sit alone unsupported. Now, can they pull themselves up to a sitting position? Yes, but they can sit there too. Just pulling yourself up doesn't mean they can maintain that position. I'll multi-select. Which would alert the nurse to hold digoxin on an infant she's caring for? Digoxin is a very, it's a drug very, very commonly given. We just give mics per kilo per dose for these things. So if we see a heart rate low, we know that's why we've got that list of heart rates. We know a newborn infant is 140 to 160 heart rate. At 90, that's like being 30 for an adult giving digoxin to. Of course, the dig level is high. That's a no-brainer. And this is the one that even if they're just vomiting, I would hold dig, and I'd rather call the doctor, get a blood level, and be safe. Because if a child's not a normal vomiter and they're vomiting, it's probably dig toxicity. And they can't tell you if they see things like an adult would. A 4-year-old is reluctant to take medicine. What intervention should the nurse take? So 4-year-olds like to make plans, they like to delay, and they like to make excuses. So straightforward, we have to give you medicine. Would you like to chew a pill or would you like liquid? You want liquid? Okay. Do you want a cup or do you want me to squirt it in the back of your throat with a syringe? Would you like juice? And that's it. Straightforward, give them the options and get it done. Don't come back later. Don't give it to the parents because they're probably going to be just as reluctant with the parents. So that is what they say to do for that reluctant child. Which concept reinforces the development of sense of trust for an infant? So this is Erickson. This is Trust versus non-trust, mistrust for the infants. What does that mean in an infant's mind? And we know an infant cries, usually if there's trust going on there, somebody's going to go pick the infant up. They're going to burp them, they're going to feed them, they're going to change them, they're going to, give them that loving hug, which is what they want. So they can predict what's coming because I cry, I'm going to get what I need. That is trust for an infant. I've mentioned that a infant who has mistrust isn't going to stop crying because they know nobody's coming for them. So that is a different sort of infant. And they had to have cried quite a bit for them to stop. An infant is NPO and unable to take breast or bottles for feeding. What is important to remember? And that's absolutely your non-nutritive sucking device. We want to give them that Freud, that bite, chew, everything in the mouth, oral, Freud oral for the infant, and it gives them comfort. It's a stress reliever. Plus, it's normal growth and development. Give them their what they need. When teaching sex education and contraceptive for adolescents, what should the nurse remember? What should they consider? Now, these are going to be questions for adolescents. So when we're talking about adolescents, and usually when this is occurring, the parents have stepped out of the room and they're asking you, so what would you use? Well, we need to give them oral and written concrete in their hand tools to look at. And we cannot infer any of our biases into that. So we will tell them, abstinence, using protection, going to, get birth control, but don't forget, using condoms, and then give it to them so they have a written form they can go back to. We don't want them to have to go anywhere else. And many parents today won't talk about it. I know I wouldn't go to my parents about that. But I mean, there are some parents today they can. My kids came to me, but that's different. The monthly immunization for RSV is so RSV, respiratory syncytial virus, is given the first year of life monthly from fall to early spring, and it's to prevent a virus which is all mucus, low-grade fevers, and it's called Synagis palivizumab. We give these to our children who are immunocompromised, could be a child who is premature, a child who has a cardiac condition, because it's hard enough to suck, swallow, and breathe as an infant. Put mucus in there and they can't breathe. I mean, infants like to breathe through their nose. They don't know to open their mouth. And if it's all clogged, guess what happens? They're going to choke and become severely respiratory distress. We don't want to put that tax on your immunosuppressed and your more critical infants. An infant with HLHS, hypoplastic left heart, becomes tachypnic, taking a long time to eat, requires rest. What assessment is your priority now? What do you think is going on? Hypoplastic left heart, most severe of all cyanotic heart diseases. They're starting to breathe fast. Well, when you start seeing breathe fast, well, but first thing, I'm going to auscultate the lungs. Breathing fast, I want to make sure nothing's in there. But when you see them taking a long time to eat and requires rest, they're not getting the oxygen they need. They're tachypnic. They're probably going in congestive heart failure. And it's as simple as listening to the lungs, telling the physician that you're listening to something. They might need, this child's probably on your furosemide, your Lasix, might need an extra dose, or maybe it needs a dose increased. When doing an admission on an infant with a low-grade fever and a loose cough, what information is priority for placement? So we will have to place infants into a room, into a bed on your floor, and they need to be placed in a correct area. You can't just put, all right, A, B, C, D, and go in a room. No, we can't. So one of the biggest priorities is immunization status. We know we've got an infection already, got a low-grade fever and a cough. Is it upper respiratory or is it something more? Is their immunization status is up to date? That's how we can put maybe 2 infants, same thing, both immunized in together. A 3-year-old is brought to the ER with increased wheezing for the last 2 days, and the child's using an MDI, meter dose inhaler. What is the most important information that you need to ask? So we need to know, was a spacer used? Was that medicine just blowing in the air, or was it in a spacer? And then, you inhaled it and they got the dose. Because if they're not using a spacer, we can say, well, it's probably they're not getting the medicine. But if they've used a spacer, we know more drastic treatment will be needed. That means maybe we need to give this child some steroids or give a couple regular aerosols to this child to help them, or even more than that. So it's very important, key information that we don't think about. How did they get it? Did they really get the dose? A multi-select. What is included in the plan of care for a child with cystic fibrosis? We know cystic fibrosis is mucus that clogs the lungs and it clogs the small intestines. It's due to the inability to break down food, to be able to eat it, to be absorbed. So we need a diet which is high protein. This high protein helps with muscle wasting. Now, these children go through a sweat test, which means there's salt on them. They're losing salt. So they're a regular salt diet. Don't confuse that with this child. That's other diagnoses we've talked about. But cystic, they need their salt. And then aggressive physical therapy, because we need to keep those secretions loose. We need to keep them coming up. Once they sit there, they clog and they become petri dishes and grow bacteria like crazy. So keep that moving, keep it out with aggressive physical therapy, ambulating, coughing, deep breathing, and incentives, spirometry, all of that. And that's daily for these children for life. And then, of course, the pancreatic enzymes, make sure that they're given directly before meals, about 30 minutes or less, and that we increase the dose as this child gets older. Which information is the most important when rheumatic fever is suspected? Rheumatic fever, acute familiar nephritis, these are 2 different diagnoses that are caused by a childhood illness. And it's pharyngitis. It's a strep infection that was either treated or undertreated, and then it went rheumatic fever. Now, rheumatic fever treatment is going to be antibiotics for a long term. Hopefully it didn't affect the heart valves, and hopefully that they haven't been damaged yet by the time we understand it. But we just treat them with antibiotics, and we can reverse all of it except valves unless they're damaged. A multi-select. What are some assessments that an infant would have if they were in acute respiratory distress? So you would see more of abdominal breathing, not diaphragmatic, but nasal flaring and grunting. Now, I've told my class, having an infant come in with retracting abdominal breathing, and then you see nasal flaring, I'm worried. But then on the end of a breath, they go, eh, eh, eh. And this is what we call a grunt. That child I'm bringing to the trauma room. This child is about ready to crash on you and needs immediate attention, needs oxygen, and needs aerosols and whatnot to help clear up the lungs. Very scary child, infant who's grunting. What is the purpose of giving indomethacin to a neonate with a PDA? Well, what is a patent ductus arteriosus? This is fetal circulation connecting the pulmonary artery to the aorta, and it allows oxygen when the heart doesn't mix right. And it's important to have it open many times. Now, normally intrautero, the body secretes normal prostaglandins and it keeps that duct open. But after birth, that prostaglandin stops being produced. So it closes naturally. On some occasions, it does not. And what we do is we give indomethacin. It's intravenously, it's given over 30 minutes. And what it does, it stops the prostaglandins from being produced at all so that it closes the duct quicker. Now, you have a patent ductus arteriosus open. You listen to the chest, you're going to hear like a machine in there, washer machine murmur. You know that duct has closed when you have a decreased murmur there. It almost goes away. One of the things that you can watch. What is the greatest risk factor for a newborn receiving a cardiac catheterization? Remember, any child going and having an echo, finding something wrong, prepare them for a cardiac catheterization. We need to look at it very closely. And as I've told my group, the first thing when I accept a child back from a cardiac cath, especially the littler ones, because they put big cannulas in the femoral artery and the femoral vein, and they hold it and they clot it off and put a pressure dressing there. But in the transport from the cardiac cath room to where they need to go, sometimes it dislodges. So it can hemorrhage. You can hemorrhage all this newborn's blood in a minute or two. That's how quick this will bleed out. So acute hemorrhage is your greatest risk factor. A 10-month-old status post VSD repair is receiving morning meds. Vital signs are as such. What meds should the nurse question? Your blood pressure 118/70, temp 99, pulse 88, respiratory rate 22. Excuse me. So again, that was the heart rate. The heart rate is telling you it's the digoxin. Now, Vasotec and enalapril are basically the same name. And these here causes the blood pressure to go down. It decreases peripheral constriction. It dilates, the blood pressure comes down real nicely. So it has nothing to do with a heart rate. So it is digoxin, lenoxin. And what do we give for a digoxin overdose? Digitoxicity, digibine, right? Digoxin immune fab. While assessing a newborn infant, you notice decreased femoral pulses bilaterally. What nursing action should you do next? What should you look for? Newborn, right out of the delivery room, right to you, you're doing your assessment and those femoral pulses are really weak. What are you thinking of that this could be? Actually, I did this when I first started newborns. I saw that there was no or very slight pulses, in the lower extremities. So think coarctation. So take the blood pressures on all four extremities, and the upper extremities are about 20 points of mercury higher than lower extremities, because the coarctation, the kink, decreases blood flow going to the lower, So that lower extremities are lower blood pressure, and it increases blood going backwards. So you have an increased blood pressure there. So very good. Some of these questions are here to try to make you think of diagnosis. How do you get an adolescent to open up about their sexual history? Number one, kick the parents out of the room, right? I know that many adolescents won't talk, and when you tell the adolescent it's a safe zone, you can talk to me, I'm trying to help you. You know, what information do you need? What can I help you with? When this child walks in and you see them listening to music, I'd say, hey, what are you listening to? Oh, and I'm like, oh, and who is that? What sort of music? Or do you see like a school letter on them? Oh, you play sports. Or, oh, those sneakers, they're some of the newest ones out there. I mean, adolescents, you're going to find something that you can start to talk to them about. And then the parents leave. Now you already got a little rapport, and you're going to say, so tell me what's going on. Are you, aren't you, you know, be honest with me so I can help you. I'm not going to tell your parents. I'm only telling your parents if there's something that could, you know, harm you or others, right? We want to protect our child again, but let them open up. I'm going to warn you, be careful. Sometimes they come up with some things that will embarrass you. So do not look shocked with things that they tell you. Say, oh, okay. And then say like, well, how'd that make you feel, right? Multi-select. When educating adolescents about risk for HIV and hepatitis, what would you include? This is part of our sexual education, right? So number one is abstinence. You know, adolescents going to do what they want. So at least tell them that condoms would be the bare minimum they should do. And then, of course, always hand washing. I hope that they're bathing more than once a week. That I would hope. What stage of Erickson would you use for a school-age child? As I said, please review your stages, infant, school age, adolescence, and what do these things mean? So it's industry versus inferiority. And what does that mean? Well, industry is being able to do something well. It might be, you know, tap dancing. It might be spelling, math, writing, something, you know, that they do well and they're looked at for that. The inferiority is things they cannot do well. Maybe they're good in the classroom and they're very awkward in sports. They would feel inferior there. So industry is the task they can master and do well. Inferiority is the things they just can't do and it frustrates them. A multi-select. Child with hemophilia has fallen, the knee swollen, painful. Treatment would include what? So it's rice. We're going to rest, ice, contain, and elevate. Never hot packs. You put hot packs on a child with hemophilia, you dilate the vessel, you're going to create more bleeding. So always cold pack when we're talking about a fall. Exercising the knee, again, will increase blood flow to it, will cause more bruising, swelling, and blood being poured in there. So elevate it and cold packs are the two answers here. Your child with ALL leukemia has recent lab results with platelet count of 10,000. What is a nursing action? Now, it doesn't matter if it's leukemia or sickle cell or anything else. You see a child, an adult with a platelet count of 10,000. What is your nursing action for that care? Well, 10,000 platelets, this is part of the coagulopathy that their child's not going to clot. So watch out for bleeding. That means no IM injections. That means do, cluster any blood draws together if you have to do. Watch the gums and check for bleeding everywhere. So bleeding precautions. Platelets low. A child starts with a nosebleed for no reason. What should you do first? So first thing you do is you take and you pinch it with your thumb and your forefinger. If you can put ice on there, that's fine. If after 10 minutes it's still bleeding, get this child to some help, urgent care, emergency room, so that we can, sometimes you have to cauterize the little vessels inside there. And you could bleed a lot through your nose. So keep it pinched and get to help. An 8-year-old semi-conscious boy is brought to the ER with elevated blood sugar, high potassium, low pH. What is your priority action? Well, looking at these signs and symptoms, blood sugar greater than 600 with already a low pH. This is DKA, diabetic ketoacidosis. I'm sure we have ketones floating in the urine too. So our priority is, number one, is to give a bolus of fluids, which is saline, and then monitor the blood sugars and get do little blood sugar, regular insulin IV, and then watching the blood sugars every 15 minutes. The neurostatus is like that because of the blood sugar and the acidosis. Once we correct it and give this bolus, and usually the first little bit of insulin, these children go from pale, leaned over, just, groggy, lethargic, to awake and alert, and now they're on their phone, texting their buddies. It's just that quick. So IV bolus, regular insulin is your first thing to expect. Child admitted with hypoparathyroidism, what findings would you see that needs to be reported to the healthcare provider? So thyroid, the parathyroid gland, works with calcium in the body. And if it's low hypoparathyroidism, we know that there's low calcium in the body. Some of calcium, magnesium, both work with muscles. So if you're seeing weakness, that is low calcium. That would be the finding that would be specific to a child who has hypoparathyroidism. I don't think you'll forget about calcium and magnesium working on muscles. And when you see something related to that, that will be your answer. A child with Kussmaul respirations due to DKA, the increased respiratory rate is trying to compensate for what acid-base alteration, or they take deep and long respirations. We know a child who has DKA is metabolic acidotic, and the body is trying to go into respiratory alkalosis to compensate for it. I mean, the body is pretty neat. Now we've given fluid, we've given insulin, the body's breathing, these long, low, slow breaths, which is, again, making the CO2 come up, and now we're going to see a change in the pH. So Kussmaul's respirations has a reason why children do that, adults also. When talking with an adolescent regarding personal health concerns, which is most important? Had a couple of questions regarding this. Again, let them be open and honest. Again, do not be shocked by what they say. Let them sit and talk about it and, see what their concerns are and how you can help them. Again, remember, it is only pertinent information, not your feelings, and to give them something written that they can go back to refer to. What procedure is priority to keep the lungs of a child with cystic fibrosis open? Just physical therapy. It's amazing how it can work. I knew this one family who had 3 boys that had cystic fibrosis. They would line them up with their vest on with their aerosols every morning, afternoon, and night in order to keep these chests open. And I just have a visual of the chest just vibrating like crazy. And one of them was a cardiac child too. In school age, conflict of industry versus inferiority. What does industry mean? Industry is they can do something well. It's mastering a task. Remember, school age likes to do things well, spelling, writing, math, or maybe that's the child in Little League and can hit home runs or the best pitcher or most steal bases. They're mastering a task. The inferiority is what they cannot do well. Contraindication to administering the varicella vaccine to an adolescent. Well, when you look at this, think varicella vaccine, what do you know about that? It's a live vaccine. So live vaccines we cannot give to immunosuppressed children or adults, and we cannot give it if you're on steroids, corticosteroids, because that renders you immunosuppressed. So very good. Early detection of hearing impairment is critical. Which one is of primary importance? And that is speech. If we are having a child who cannot hear well, their speech will be garbled. In fact, if we're seeing that the speech continues, even as they grow, they're not able to pronunciate well, we need to do a hearing check on these children. If you can't hear, you can't speak it. In helping a child to adapt to a hospitalization experience, the best approach is especially your younger children, when you change the routine, when you go on vacation and bedtime's different and, when you wake in the morning's different, the younger children, especially toddlers, don't do well. But put them in a hospital, keep them on the same nap time, the same sort of meds, the same bath time, the same everything as much as you can. And this child is going to be happier because they can see what is coming next. When assessing vision on a child, the healthcare provider would use a Snelling chart at what distance? And then I'll ask you, what happens if all the stuff is blurry at 20 feet? Well, we know that this child now is probably going to need glasses, right? Can't see 20 feet. How severe is it? Referrals for cognitive impairment should occur when? And it's what we call early intervention. As soon as you can figure out with those growth and developmental markers, something's wrong, they're not up to the level, get it investigated and start early intervention, speech, physical, occupational therapy, ASAP, yes. How would you help encourage a preschooler to be less apprehensive when taking their vital signs? Preschooler, ages 3 to 4. These guys are really alert and they're really understanding the environment around them. And they've probably or may have had a bad experience before. So let them play with the equipment. I play with numbers, telling them, oh, I have this number. What's your number going to be here? Push the button for me. If you can help me, I can get it. Where do you want your blood pressure taken, here or there? And you do those things and the child's going to be more excited to see what the numbers are, especially a blood pressure. That squeezing, most 3 or 4-year-olds, they don't like that. The nurse is discussing sexuality with the parents of an adolescent with cognitive impairment. What is important? You have an adolescent with cognitively impaired, could be a mild Downs, and some of these mild Downs can live on their own eventually. So we need to prepare them for life And we know not everybody's nice people. So they need a well-defined, concrete code of sexual conduct. What's a good touch? What's a bad touch? And what to do when they're not getting a good touch. And, you know, to save these children, adults and adolescents from getting abused, because people are abusive out there. So they need to know concrete code. What acid-base imbalance may you see with a child having profuse diarrhea? So when you're having diarrhea, alkaline is leaving. It's not acid. Stomach is acid going out, but diarrhea has the enzymes from digestion. And these enzymes create a more alkalotic state. So you're getting rid of alkaline. That means you're left with acid. So the answer is metabolic acidosis, okay? Now, if you were vomiting, you're getting rid of acid like crazy, stomach acid, you would be metabolic alkalosis. I don't know if I can make that clearer, but you're going to see acid-based questions on your med-surg, and you're going to see it on pediatrics. Multi-select. If an infant has not passed the meconian stool in the first 24 to 36 hours, what would you assess for? I think there was like 3 weeks in a row we were talking about stooling in infants, and the first day, day and a half, not having a stool. What could it be? Well, Hirschsprung's, remember the big outpatching, it's aganglionic. There's no nerves in there, with a tiny little connection to the anus, which could have little ribbon stools, maybe. We know cystic fibrosis is one of those, and hypothyroidism. And it's usually why we'll end up checking for that, is because of no stools. And that could be the only hint we have that they have cystic fibrosis or hypothyroidism. And we know if we do not give thyroid hormone to an infant with hypothyroidism, they're going to have cognitive delays. They're going to have struggles in the future. So as soon as we can put them on those supplements, better. And it has nothing to do with electrolytes at all. A child with sickle cell disease would most likely exhibit what sign? And you would usually see a child, now they have a bunch of things going on, but usually what brings a child into medical help is the pain. They can't stand the pain anymore. Now, are they dehydrated, tachycardic? Probably. You probably have a child with an infection, low-grade fever, probably that sleepiness, lethargy due to low hemoglobin, hematocrit. So it could be all those things, but what brings them in is the pain. When teaching the child and family about celiac disease, which of these food items is allowed? So wheat, rye, and barley, no, but we can have rice. So thank God today they're making rice flour. We can have breads and cakes and stuff for the child with celiac disease, even the adult. A 6-year-old goes to the ER due to abdominal pain, fever, vomiting for 24 hours. What assessment is your priority to look at? I mean, you think abdominal pain, is this a surgical emergency or what? When you see fever there, it makes you wonder. It could be an appendix, right? It could be something else. So description of that abdominal pain is very important. And where is it? And then we'll assess for dehydration and start an IV and do lab works, of course. A multi-select. Signs and symptoms of hypertrophic pyloric stenosis. Remember, the pyloric sphincter gets thickened and muscular in the lower stomach, the connection to the small bowel. And what we'll see is a projectile vomiting across the room. Now, whenever I have an infant, usually those 3 weeks to 3-4 months, I will ask them, so tell me about the vomiting. Does it dribble or does it go projectile out? And if they say projectile out, the next thing I'll do is feel their tummy right below the xiphoid process. And you could feel, and it feels like an olive in there. So those are two things. Actually, these children are hungry. They keep losing their food, so they're hungry. Nothing's going down. So not a poor appetite. They're going to be crying because they're hungry. They're not getting food. A multi-select. A child with chronic kidney disease has renal osteodystrophy. What outcomes would you see? We know that chronic kidney disease, we don't have enough red blood cells. We give erythropoietin for that to prevent the quantity of blood transfusions. We know it has a problem with holding on to vitamin D. Vitamin D is very important for bone and bone growth. So you have low D, you're going to have the bone growth's going to be slower, right? So you're going to have a slow growth and you have the bone pain there with it. Has nothing to do with heart rate. Vitamin D has to do with bones and bone growth. You suspect an infant has cryptorchidism. How would you examine this infant? Cryptorchidism, we have testicles that didn't descend, they're up in the abdomen. And we know every male that goes to pediatrician first visit, he's going to look at that scrotum and look for those testicles. But men, if they're cold, we know that their sacs get tight and they go up because they're cold. So put them in a warm room and then you might be able to feel the testicles on some of these infants because it still could be up there pretty high. A multi-select. What teaching would you give parents on how a hypospadias is corrected? Now, the big thing with a hypospadias or epispadias is that if you have a infant of Jewish faith, they do this big ordeal where the rabbi does a circumcision for the male. It's this big part of birth and the entrance into the world. You cannot let them do that. So they have to understand that when they do this correction, they use the foreskin in order to do a surgical covering of that hole. It's a plastic thing, and then they put the stent in there. And it actually looks like a female straight calf stent, that clear, like 8 French tube. And then when we have that stent in there, we leave it alone. We don't touch that thing. All we do is put a gauze on it, and then eventually, like a week later, you go to the GU and they'll pull it out. But you just leave it there. It just keeps the maintenance of the patency of that lumen open is what it's there for. So the big deal is the Jewish faith with that one and explaining it to the parents. Multi-select. A child with nephrotic syndrome are often given albumin and Lasix for fluid overload. What outcome would you see after giving these meds? Remember, nephrotic syndrome has not a thing to do with kidney failure. Nephrotic syndrome is that they cannot maintain protein. They lose protein. So if you don't have protein intravascularly, you'll see fluid go interstitially and you'll see swelling everywhere. So we give albumin, which is protein, back intravascularly. It pulls the fluid from the interstitial space. Then we give Lasix and it should push it through. We should see an increased urine output, reduction of the edema, and of course, those blood pressures should come down also. A 2-year-old goes to the ER with inconsolable crying and a painful abdomen. What finding shows you this is a medical emergency? So when they're inconsolable with painful abdomen, that age, 2-year-old, this is a possible intussusception. The intestines has pulled and telescoped up into each other. And when it's inside each other, it's extremely painful. There's nothing you can do. Those legs will be kicking on this poor child and they really hurt. But you go into the diaper or into their underwear and you see this current jelly looking stuff with maybe streaks of blood in it, you know then it is intussusception. We need to do that ultrasound, find it, and we need to reduce it, whether in the radiology department with an air embolus or surgically. I've never seen one go to surgery, only to do that air enema. When assessing a 2-month-old with vomiting, what questions should you ask the parents? Again, when they're vomiting, we want to know how. Is it dribbling or across the room? We know that if we know it's projectile, we're going to tell those parents, please stop feeding your child. We know they need to go to surgery. Start an IV and just keep them NPO until they get upstairs. The forcefulness of vomiting and just the reflux, and remember, as we're looking at this child, a 2-month-old who maybe just has reflux, we got to look at the weight, because whenever we have a child in, whether it's a doctor's office, urgent care, ER, we weigh them. And if they're not gaining weight, then we know that we need to do more for that child, because they can lose a lot with just dribbling. You notice a 2-year-old with congenital heart disease, their heart rate is decreasing. What other information is important? So other information for the healthcare provider, something just not right. 2-year-old. Again, looking at that vital sign sheet, knowing what is normal, but the urine output of 20 mLs per hour is okay. It's 0.5 to 2 mLs per kilo per hour. That actually comes out to be okay for this size child. That blood pressure is low. That means the organs aren't perfusing. That means this child is having trouble with the heart not bumping effectively. They need medicine to help them. They could be placed on a dopamine drip or something to help that heart beat more effective, because at this time it's not. A multi-select. When entering the room of a child, the child becomes stiff and the arms and legs start shaking. What's your priority actions for this? So, of course, when you go in there and say, notify the response team, just in case you need more help. You don't know when that seizure is stopping. Monitor the time and duration, and then, of course, keep this child safe. Put the bed flat, turn them to their side, remove pillows, pad the side rails. All of those things is just to protect them from safety. And this child, if they need the response team, they'll be on their way. So put them on their side, and if you have suction there, it'd be great, but nothing in the mouth. Don't force nothing. A 3-year-old with a waddling gait and falling is admitting for testing. What examination should you anticipate? Waddling gait, lordosis, Gower's sign. That means the muscles are failing. They're not working. Waddling gait, just think of the muscles aren't working. So this is Duchenne muscular dystrophy, most likely. And how do we finally get a diagnosis? A lot of it is the symptoms, but the EMG, the electromyography, shows if the muscles are responding to the nerves. Remember, this does hurt. It is uncomfortable when it's being done. I've had it done, so I'm telling you, it is uncomfortable. Make sure that we medicate them for pain. It's going to be, maybe a day or two. It's like you worked out and you're not used to being worked out. A mother calls the clinic about her child. She's playing in the woods and has a rash that is spreading. What over-the-counter is good? She asked you, says, what over-the-counter can I give this child? She has a rash that is spreading. And because it's spreading, you don't know if it's going to go anaphylactic. You should never recommend and get them to medical attention, whether the doctor, urgent care, somewhere. Get them to go be seen, because we don't know the rash. We can't see the rash. We don't know how quick it's spreading, and we don't want to do anything to harm our child. A mother calls the clinic again. A friend of her child's has ticks from playing in the field. What do you tell the mom to do? So with ticks, all you do is an examination. Look, try to get all the tick pieces out. If you can't, then you call the your pediatrician and get in to see them. But it's just checking it and making sure that it doesn't go further than just on the body right now. It takes a while to burrow in, so get them off as quick as you can. An adolescent goes to the school nurse because they're complaining of ringing in their ears. What exam should you do first? I mean, adolescents always have their phone in their ear, they have music in the ear, something's always going on. But the first thing is obvious. Look inside. Ringing in the ears, I've actually seen roaches in the ear, and they could be buzzing in there. It could be something. So first, look in the ear, and then you could look at the rest of the stuff, and it could be something with a blood pressure, but first is to look. And last question for today, a multi-select. An infant's being discharged after 14 days of vancomycin. What teaching should be included? Now, vancomycin, very strong aminoglycoside, could be used for staph, could have been osteomyelitis, could have been a meningitis. And we know monitoring vancomycin as we give it is so important. So these SINs, aminoglycosides, we know they do two things. They can hurt the hearing, they could damage it, and also the kidney. So monitoring, number one, their hearing responses, are they still listening well? And the wet diapers still would be continued monitored, just to make sure that we can see that the medicine is going out of the body, and that they can hear and they're still urinating. A trough later on is going to do nothing. And we're going to give NSAIDs to a child if they have osteo or meningitis and have headache or whatnot, for sure. But it's the vancomycin that our teaching should be concerned about. Number 3 is Gigi. Good job, Gigi. Oh, Kim, look at you. Good job. Number 1, Regina. Good job, Regina. And RIP and Meg. Okay, guys, I did the new review today. I'm going to send you the old one. You can look at the questions also. There's some of those questions that you'll see. I'll be posting them on your announcement sheet with all of their reviews. I just wanted to come in and do another one so that we had one separately for all of the sections, and then a review again, listening to these concepts, because many of these concepts are on HESI and will always be seen on your NCLEX. So thank you all for coming to me on a Sunday morning, afternoon, and I wish you all the best on your HESIs. Let me know how you do, okay? Appreciate it.
Great. Thank you.
Thank you.
Thank you so much.
My pleasure.